Hello, I'm Dr. Ken Landa. Thanks for watching. Let's talk about depression. Depression has been known about for thousands of years, but the modern concept only evolved in the 1960s and 1970s. Now, depression is extraordinarily important. It's a very common condition. About half to two-thirds of people with depression are going to seek care at the family doctor. In the United Kingdom, it's going to be about 90% of people. World Health Organization says more than 300 million people in the world suffer from depression, with the incidence rising at least 20% over the period of the past 10 years. Now, the incidence occurs worldwide. So it occurs in high-income countries, low-income countries. It's not due to poverty per se. During the course of 12 months, the likelihood of an individual suffering from depression is anywhere between 4 and 6%. Over the course of a lifetime, it's somewhere between 15 and 18%. That means about 1 in 6 or 7 people will suffer at least one episode of depression. It's estimated that maybe as many as 1 in 10 people seeing a family doctor has depression. Well, unfortunately, we have a major lack of reliability in the diagnosis for this condition. We don't have any blood tests or urine tests. We don't have any imaging tests to make the diagnosis. So that means that it's all subjective. Yeah, we have some checklists and some questionnaires, but basically, one doctor can diagnose depression, and you go see another doctor for a second opinion, he says you don't have depression. And unfortunately, we don't have any way of determining who's correct. But we do know that if you do suffer from depression, it's going to severely limit your psychosocial function and decrease your quality of life. But we have major issues with the detection, the diagnosis, and the management of the condition. Poses challenges, various presentations. It's an absolutely unpredictable course and prognosis. Could be chronic or recurrent. We have a variable response to therapy with depression. And unfortunately, the use of the term in the general public, I have depression, versus the medical disorder of depression, major depressive disorder, completely different. Now, the first episode of depression tends to occur between mid-adolescence and the mid-40s. About 40% of people develop depression for the first time, although it's undiagnosed frequently, prior to age 20. The average age of diagnosis, average age of onset, is 25 years of age. Ranges anywhere between about 18 and 43. We have 2 peaks of incidence. Seems to be in those people in the 2nd and 3rd decades of life. And then we have a more modest peak in the 5th and 6th decades of life. If you have one episode of depression, chances are at least 80% that you're going to have another episode. And women are going to be about twice as affected as men. We know that the onset of depression tends to be relatively gradual, although sometimes it could be acute. Course is variable throughout lifetime. Symptoms tend to come and go. Between the episodes, you may feel perfectly normal, but this is an inherently unpredictable condition, so you're going to have a variable number of episodes throughout the course of a life. The average number is about 4, but it could go from very few, or even 1, to maybe chronic depression, where the symptoms just don't seem to go away. Well, since the condition tends to be so variable, we look for certain groups who might do better. And we have 2 different groups. We have basically the group taken care of in family practice, group out in the community, and we have the group that has symptoms so severe that they have to be hospitalized. And when we talk about recovery, we're talking about mostly those people who have the less severe depression, those people who are in the community setting, in the general practice. They have a higher recovery in 1 to 3 months. Their episodes tend to last about 3 to 6 months in about half of the cases. Average duration of depressive episodes, about 23 weeks, with about 75% recovering in less than a year, which unfortunately means that 25% are going to take a lot longer than a year to recover, if they do recover. Likelihood of recurrence of the condition, every time you have an episode, you're more likely to have a second episode. And if you have a second episode, you're really likely to have a third. And if you have a third, oh my goodness, a fourth is almost assured. And we have a less favorable outcome in depression that tends to begin in an older age population. And then we also have a problem with comorbid disease. So we have other kind of conditions that you might have. You might have some somatic symptoms. I'll tell you about those in a moment. But if you have somatic symptoms or you have greater incidence of mental dysfunction at the baseline, then you're probably not going to do as well over a longer period of time. Now, in one study where they looked at the outcome of depression over a long period of time, they found that about 17% had a chronic course. They still had symptoms at 3 years. About 40% had fluctuating course, tended to come and go, and 43% had remission of their depression. Well, one of the problems with depression is a marked increase in the incidence of suicide. I have to be very careful with patients who have depression because the incidence of suicide is higher than in any other psychiatric group. Well, another issue is these comorbid diseases. So it tends to be that if you suffer from depression, you have a higher chance of suffering from mild conditions like gastroesophageal reflux disease to hypertension or coronary artery disease or diabetes or anxiety or epilepsy. And whether it's cause and effect, can't tell you. But we can tell you that if you're taking prescription medicines, you have a significant likelihood of depression, depending on what the medicine is. And depression is a relatively common complication of a variety of different medicines. And people who have depression have a lot of pain. 2/3 of the people who have depression have pain. And we know that a lot of people, because of their depression and because of their pain, they tend to abuse substances. And if you have HIV or if you have Parkinson's disease, that's going to increase the risk of depression. And the medicines that seem to be most frequently associated with depression would be interferon, used to treat a variety of conditions from cancer to viral infections. The beta blockers that are used for high blood pressure and certain cardiovascular problems. Isotretinoin, same thing as Accutane, used to treat acne. Birth control pills and cardiac agents and even antipsychotic drugs can increase the incidence of depression. Well, the risk for depression seems to be a prior episode of depression. It seems to be if you have other medical disorders, substance abuse, if you have a chronic medical illness, if you have poor social support, a stressful life, intimate partner violence, they all increase their risk. And now we have the American Psychiatric Association that doesn't seem to be very helpful at all, some people would say. They have their Bible of psychiatric diseases. It's called the Diagnostic and Statistical Manual, 5th edition currently out. And it lists 8 depressive conditions: disruptive mood, dysregulation disorder, major depressive disorder, persistent depressive disorder that used to be called dysthymia, premenstrual dysphoric disorder, depression from medical substance use, maybe depression from another medical condition, maybe a different depressive disorder, maybe you're suffering from melancholia, maybe you have bereavement. It used to be said that if you lost a significant other and you were suffering significant bereavement, then you couldn't have major depressive disorder. There was an exclusion. Now it isn't. So if you have severe symptoms and they persist beyond the acute grieving, then yes, you can have major depressive disorder. And now we have some new species of this condition. So we have mixed features where you can have major depressive disorder and you can have up to 3 hypomanic or manic symptoms that aren't really sufficient to make the diagnosis of bipolar disorder. And then we have anxious depression. Anxious depression combines anxiety and depression. Now, these people with anxiety and depression combination, or anxious depression, they tend to have fewer remissions, longer time to remission. They tend to be more likely to need hospitalization, more likely to commit suicide attempts. They have presentation with more somatic complaints. They complain about the heart, the lung, the kidneys, all sorts of different kind of problems. They tend not to complain of the depression. Well, if a person has anxiety and depression together, it seems that the anxiety tends to occur maybe a year or 2 years ahead of the depression. And with increased age, the anxiety becomes more pronounced, and the medicines that are used to treat the depression tend to work less well on the anxiety. And then we have adjustment reactions that are different from bereavement. So here you have an identifiable stressor, and within 3 months of the onset of the stressor, then you have significant distress. And it may or may not meet the criteria necessary for major depressive disorder. And then you have major depressive disorder with psychotic disorder, psychotic symptoms. So these are people who have the depression, and then they have delusions. They feel worthless, feel like they're a failure, or they have hallucinations. They hear voices telling them they're worthless. They get angry for no apparent reason, spend hours in bed. They have intellectual impairment. Oftentimes they may end up hospitalized. And each time they revise the diagnostic and statistical manual, the people who are in the field say it makes the diagnosis less reliable, so that at the present time in DSM-5, they say it might be useless. So how's the family doctor to keep up with all of this? Well, the condition itself, depression, costs society in excess of $200 billion every year, and that number has increased by almost 25% over a period of the past several decades. Well, how do we make the diagnosis? We make it through symptoms. So we sit and talk to people and see how they feel. But the most important thing to realize is that none of the symptoms of depression are pathognomonic of depression. So none of them say, hey, you have depression. All of the symptoms are present in other kinds of disorders, medical disorders and psychiatric disorders. So that lends problem to making the diagnosis. And then there's a question about priority of symptoms. Which symptoms are more important or less important? Well, we just don't know at the present time. So what kind of symptoms do people have? Well, many times people are going to complain of neurovegetative symptoms, the somatic symptoms. So they're going to complain of fatigue or headache or digestive problems, abdominal pain or decreased appetite, decreased weight. They're going to be agitated or lethargic. Sometimes they complain that they lack energy, or they have cognitive symptoms. They think they have mental slowing or getting forgetful, or they suffer from insomnia. Other signs that might take people to the doctor when depression is really the cause. Maybe they just complain of general aches and pains, or back pain, or sexual dysfunction. These are the people who go to see doctor after doctor. I can't get any answer from the doctor. He doesn't seem to help me. Well, it might be that the symptoms aren't what they appear to be. It might be that the symptoms of the back pain and the digestive problems and all of that is a sign of a psychiatric condition, oftentimes depression. And unfortunately, the same thing with anxiety. And if we're talking about children, children tend not to have obvious depression. They present with irritable mood or a decrease in their academic performance or moodiness. And all of that obviously leads to a delay in making the diagnosis. Now, do we screen the population for depression or not? We have a whole bunch of questionnaires that can be used, but you can't make the diagnosis of depression on the basis of a questionnaire. You have to talk to a person. So there's question about how useful it would be to screen the general population. Some organizations say yes, some say no, some say, well, let's look at the postpartum women, let's look at older adults, let's look at people who are more likely to suffer from depression than the general population. Well, how do we make the diagnosis? We have a condition where you can make the diagnosis on just one episode of depression that lasts nearly every day for about 2 weeks or more, but sometimes there's no resolution, and then you have the symptoms for an extended period of time. So now you have chronic depression, and sometimes you can have relatively mild symptoms for most of the days for couple years. We don't have any remission for a period of months. Well, these people might have a persistent depressive disorder, or they might have what we call a subsyndromal depression. In other words, they don't really classify for depression the way we currently define it, which is absolutely arbitrary, and those people might not then be candidates for therapy. Well, we have a variety of questionnaires. We have the Hamilton Depression Index, we have the Beck Depression Inventory, the Montgomery-Asperg Depression Rating Scale, the Suicide Behavior Questionnaire. We have all sorts of questionnaires that can be used for the general population, and that's just a little tiny fraction. And we have another problem with making the diagnosis of depression. Most people who have bipolar disorder, which is common, most people with bipolar disorder present with depression. They don't present with the mania or the hypomania. So you have depression. So how are we going to differentiate the depression of bipolar disorder versus the depression of major depressive disorder, or what we call unipolar depression? Well, it's basically impossible. But if we treat somebody who has depression as the first symptom of bipolar disorder, and we use the standard antidepressants, and we don't use any mood stabilizer, then that person is likely to be thrown into an episode of mania. So that requires some caution. And we have to exclude being unhappy or feeling sad. So to make the diagnosis of depression, you have to have at least 5 of 9 specific symptoms. Now, that's according to the American Psychiatric Association, according to the International Classification of Diseases, which is used everywhere else except for America. They say there's no limit on the number of symptoms that you have to have. You just have to have symptoms that are causing you to have a difference in your previous level of function. So there has to be significant change. And remember, a lot of people have what we call sub-threshold depression. So they don't really make the grade for the way depression is currently diagnosed. They don't have the severity of the symptoms. They don't have the number of the symptoms. But again, all of that is arbitrary. So for the diagnosis, you have to have at least 5 symptoms. And remember, they have difference between one doctor and another. And if we look at those 5 symptoms, well, at least one of them has to be either depressed mood for most of the day, nearly every day, reported by yourself or other people, or a decreased interest or pleasure in almost all of the activities for most of the day, for nearly every day, for that 2-week period. And we call that anhedonia. And then in addition, we have to have a variety of other kinds of symptoms. So the other 9 symptoms, those are the first 2 that I just mentioned. Now we have the other 9. Increase or decrease appetite, leading to either weight gain or weight loss, insomnia or hypersomnia, where you sleep a lot, psychomotor agitation or retardation nearly every day. But the agitation might be similar to what you see in mania. Maybe it's a suggestion that bipolar disease is going to emerge. You have to have fatigue or loss of energy nearly every day. Well, how many people don't have that, especially in the middle of the COVID epidemic? Feeling of worthlessness or excessive or inappropriate guilt nearly every day. Decreased ability to think or to concentrate nearly every day. And recurrent thoughts of suicide. Suicidal ideation. So if we look at those, and they cause impairment in your social function, your occupational function, your other function, and it's not due to substance abuse, not due to a medical disorder, not due to low levels of thyroid hormone, not better explained by another psychiatric disease, then you may be suffering from depression. Well, as far as depression is concerned, making the diagnosis, the British Medical Journal Evidence-Based Medicine, 2019, says the diagnosis of depression is not built on any etiology or pathophysiology. We don't have any objective tests. We don't have any laboratory tests. We don't have any blood tests. all we have is a structured interview to make the diagnosis, well, that's absolutely inadequate. Suicide, again, is a major issue. So unfortunately, depression not only can interrupt your ability to enjoy life, but it can also cause you to think about ending your life, or can actually lead to an end of life. Especially if you happen to use excessive alcohol or substances, you're addicted to other kind of drugs. And many of the people who commit suicide have been seen by the family doctor within a period of the past 2 months. But they didn't give any evidence that they were at risk for suicide. And by the way, about half of all male suicides related to firearms. How do we work up medically a person who might have depressive disorder? Well, you know, it's the history and physical examination as always. Check the thyroid, the T4, make sure the person's not hypothyroid. Check the calcium to make sure it's not too high or too low. Check the blood count and the SED rate, and some people would say the testosterone in men who have depression and decreased health. Some people check vitamin D. But we don't have any single pathologic model to explain what depression is. We think that it's a combination of some genetic abnormality, some environmental problem, might be learned behavior from childhood, or abuse, physical or sexual abuse, might be anxiety that seems to be associated with it, might be a person's biologic makeup or culture, maybe it's the psychological makeup. And the theory is that, oh, maybe it's the monoamines, maybe it's serotonin or noradrenaline or dopamine. And we certainly have drugs that seem to act on those different chemicals, or are said to act on those different chemicals. And they work variably. They take time to work. People might find that they work in one episode, they don't work in another episode. So we don't think that those are really the answer to depression. We have the idea that the hypothalamic pituitary adrenal axis might be off, might have something to do with inflammation, might have something to do with your immune system, might have something to do with the cytokines, might have something to do with a variety of changes in the brain itself. We call it neuroplasticity and neurogenesis. We think that the brain cells can develop, although slowly, but they can develop, even though a person's an adult. Used to think that they didn't divide, now we think that they can. Well, genes might be an issue. It's thought that probably a third of major depressive disorder is heritable. Probably about a 3-fold increase if you have another first-degree relative who suffers from depression. We now have identified more than 100 genes that have some role in depression, but they seem to individually have a small effect. And unfortunately, we know that if we look at different laboratories, one laboratory tends not to be able to confirm an abnormality found in the first lab. And a second laboratory or a third laboratory can't confirm any of the other changes. So we don't exactly know what the role of genes is, but it would appear, at least at the present time, that genetic explanation might be against serotonin as being one of the major problems associated with depression. There's epigenetics, and now perhaps the most promising of all mechanisms is that maybe this is a condition that has to do with your gut microbiome. The gut microbiome making a whole lot of different chemicals, and if they can get into the bloodstream through a leaky gut, then that might be the cause of depression, at least in some individuals, if not most. That's sort of where science is headed right now, that maybe the gut microbiome is really very important. So we have this condition of depression, that's very common, affects 4 to 6% of the population at any given time. over the course of a lifetime, maybe 1 in 7 individuals. It's a term used in general society, but it completely lacks meaning in a medical sense, the way it's used in general society. Nothing specific about symptoms that identifies a person as having depression. And we know we don't have any laboratory tests, we don't have any imaging studies. We know that one doctor says you have depression, another doctor says you don't have depression. American Psychiatric Association keeps changing the diagnosis of depression to a point now where some people suggest that the current diagnostic and statistical manual is totally worthless for making the diagnosis of depression. We need to have some sort of marker for depression. We need to have some sort of abnormality that's reproducible that we can use to make the diagnosis. And then maybe psychiatry and the treatment for depression and the diagnosis of depression can take a step into the 21st century. Anyway, thanks for watching. If you enjoyed the show, please tell a friend. Consider subscribing so you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.